And I think screening is something I feel really passionate about. I feel that one of the important role of family physician is to provide screening. And I think screening is something I feel really passionate about. Let me see what's happening now. I have a double here. I feel that okay, close. One of the important role of family physician is to provide screening. And I think screening is something I feel really passionate about. Let me see. Okay, I'll close this. Okay. Right. So we're talking about cervical cancer screening and all the screening that we do in women. After the age of 40, a lot of the screening programs will kick in. We know this. Some of you might have experienced some of you have already done pap tests, cervical cancer screening, mammograms, and so on, right? So some of you know about the screening, but it is to raise the awareness and talking about the importance of screening, talking about the importance of immunization, which is so important, I think, to prevent things from happening. And as I said, as a family physician, my role is not let things happen. Well, try not to let it happen and do the prevention part, because I think prevention is so, so important. And that's how we have these programs. Like screening program would not exist if we didn't have that foresight that we can do something about it, right? So the Ontario government has come up with these screening program based on the efficacy and how smart and realistic these screening programs are, and therefore we offer the screening program. Most of them will start after the age of 40, like breast screening, but cervical cancer screening starts at the age of 25. So what I'm going to do, I'm going to share my blog with you, which I have created. It gives me a structure and it gives you a structure to look at. And I'm happy to share this blog with you later on. So I'm not sure if you can see this blog or not, if I'm sharing the right thing here.
Is the cancer and HPV?
Yes, correct.
Yeah, I can see that.
You can see it? Okay.
Yeah.
Okay.
Yeah, we can see this.
Yeah? Okay.
Yes, yeah.
Good. So this is the one, yeah. I'll maximize the screen so you can see the blog. You can see, everybody can see the blog here? Okay.
Yes, again.
All right. So Nicola, we just started, we're just talking about the screening in women. I've literally opened up the document to share with you, the document that I have created. So you can see what we're discussing, okay, and what I have prepared for you guys to share with you all, okay?
Thanks.
So I'll go on that document that I'm sharing with you. I'm just on this new computer, just trying to figure out a few things here and there, a little bit of here and there, and I'm getting a little bit confused, I have to admit. But let's see, where's that gone? I think I've here we are. Oh God, I'm working on my husband's Mac today. Wish I had not. I should have settled down for my own computer, maybe. Okay, got it. Okay, we're talking about cervical cancer and HPV associated screening. So cervical cancer screening has changed a little bit. It used to be pap test. Now it's HPV screening. And it's caused primarily, we know that there's a strong association between cervical cancer and HPV, human papillomavirus. So the cervical cancer is caused primarily by the persistent infection with a high risk type of human papillomavirus, especially HPV 16 and 18. In Canada, the incidence is 7 to 8 per 100,000, which is quite a lot. It's not a big number, but if you see the age group, because the HPV exposure happens very early on, so we are not targeting just the older population or middle-aged population. We're talking about the whole population group from young to old, right? So 7 to 8% per 10,000, 100,000 patients. Mortality has declined because of screening, because we started to pick up the changes early, and we are targeting women early through the screening. So the peak age is 30 to 50 years. Risk factors are persistent high risk HPV, early sexual activity, smoking, immunosuppression, multiple partners. Immunosuppression means somebody who has HIV or they are on chemotherapy drugs. So, what happens? The virus will just flourish because it's not being suppressed by the immunity, right? So, it will be flourishing in that case. Persistent high risk HPV infection will be one of the significant causes. So, HPV and cervical cancer, there's no denying that they're two linked together. So now what Ontario cervical cancer screening program is doing, we're not checking for your cells anymore. What we're doing is we're checking for the HPV virus. And screening starts at the age of 25. We do it every 5 years. And it will finish at the age of 65 if you had normal smear, normal cervical screening in the past. If your cervical screening was not normal, you will go beyond 65. So HPV is a necessary cause for 99% of cervical cancer. So now we know that the HPV is a problem. It's a huge problem, and it's 99% of cervical cancer that are linked to it. It's also linked to vaginal vulvar cancer, the HPV is, and also oropharyngeal cancer. So even some mouth cancers, we found out that the virus is active. Everyone can hear me still? Yeah? Can one of you say yes? So
Yes.
Yes, yes, yeah.
good.
Yes.
Because I've made a full screen and I can't see you, and all I see is my talk. So please let me know if there's any issue in between. A screening interval, it's done every 5 years for those who are HPV negative. But if somebody is immunocompromised, so somebody's on a chemotherapy drugs or somebody has HIV, then we'll do it more frequently. Management, what do we do about the results? So when I get the result of HPV infection of the cervical cancer screening, it shows me HPV negative, and we say, okay, fine, it's all good. We don't need to do much now, and you go on 5-year screening now. However, if you turn out to be HPV positive, then what we do is, in that case, we have to see what kind of HPV is positive. So if somebody is positive for HPV, the lab will automatically not just look at virus, it will go and check the cells. Yeah. So high risk is HPV 16, 18, and 45. So when I get a report, and if it tells me it's those 3 types of HPV, then I will immediately send you to a specialist, and they'll do a colposcopy, which is like a more detailed examination done by a gynecologist. And if the HPV is positive, like it says that other high risk HPV, when the other high risk HPV comes up, I'm not that concerned. Then the guideline says that we have to see, along with those high risk HPV, what is the cells like. So if it shows the cells are low risk or it's low grade, then we do the HPV test or cervical cancer screening in 2 years. If your HPV is positive, and after 2 years, let's say we did the HPV, let's say we did cervical cancer screen, it shows that other than HPV high risk, you also have low grade changes, then we'll do the test in 2 years. And after 2 years, if you're still positive, I refer you to a specialist, okay? And that's the scenario when we have high risk HPV, but not 16, 18, and 45. Remember, 16, 18, 45 are very high risk, okay? We shouldn't call them high risk, you say very high risk. So if still HPV is positive, after the 2 years, we send you to specialists. if the HPV is negative, then you go back on 5-year cycle. So there's a guideline, there's a very clear guideline that comes from cancer screening. So ministry gives us a guideline and we follow it. So if somebody, who do we refer? So if somebody is positive for HPV 16, 18, and 45, I would refer them to the specialist. I'll not even think about it. If it's a high-grade changes in your cells, so these are the high-grade changes, a bit technical, it's HSIL and AGC and ASC, then also I refer you urgently. If there's a suspicious lesion, so I'm doing a PAP and I see something there which I think is suspicious, I'll send you to the specialist. Okay, so these are the special scenario. Now, if somebody is immunocompromised, like patient has HIV, and they're transplant patients, so they've got like, kidney transplantation, and they're on certain drugs, then they should do every 3-yearly test. When to stop screening? Once you turn 65, we stop it. 65 to 70, we say. And however, if there is some abnormal screening result that we have at the age of 65, we'll continue doing it till the age of 74. So we end at 65, but if somebody is high risk, we'll continue. Key clinical principle, cervical cancer is almost always HPV driven. Please remember this. And HPV will happen well before we see any changes in your cells. HPV testing is more sensitive than PAP test, so we have switched from PAP test to cervical cancer screening, which is HPV. Now we do every 5-year, not 3-yearly. So these are big changes, and this only happened in 2025. So I think that's interesting, right? Now, what do we do now is that we follow that guideline very closely as physician, and we also encourage you. We also tell you that think about the vaccine, because HPV is significantly vicious virus. It can cause genital cancers, cervical cancer, and also mouth cancer. So we should be thinking about getting Gardasil vaccine. Now, in school, kids receive the Gardasil at the age of 9 to 14, or people who are over the age of 15, but they're immunocompromised. This is through the government. But if somebody like me, I'm not born in Canada, I didn't receive my Gardasil, then I should go get a prescription from my family physician, get a private prescription, and get the HPV vaccine. It's basically the regime is 3 dosages, 0 month, 1 month, and 6 months. So you need 3 vaccines. They're expensive, probably $150 to $200 each, but your insurance might cover. So this is a kind of protection we'll get through the HPV from the virus. Next thing is that we talk about, if you want to talk to me about HPV vaccine, getting the vaccine, please do. If you have benefits, just utilize them to get the vaccine. So cervical cancer risk, it reduces, so it's significantly reduction, right? So if somebody gets the vaccine, the cervical cancer risk is reduced by 90%. I think it's a big number. Precancerous lesion also are reduced, and population level reduction happens if the larger population gets the vaccine. So we get some immunity overall. So that's the cervical cancer screening. Next one, I think it's useful to know about these things. Then you can come back to me about getting the vaccine, or you can ask me any questions specific to the screening, right? If you're aware. Next, we have HPV immunization. We discussed that, so we've gone through it. Now the breast cancer screening. No need to mention It's the worst kind of cancer. I just feel awful that women are so high risk. Like, I think the incidence is 1 in 8 women, but if I think about how many patients of mine had breast cancer, I'll say so many. And I feel so helpless that we can't do much really, right? It's one of those things that exist, and we as women um, are high risk for breast cancer. So 1 in 8 women in their lifetime can get it. It's a big number, I think. It's the most common cancer in women in Canada. Peak age is more than 50. Usually it happens after the age of 50, but we see young people too. The risk factor, age is a risk factor. Of course, the more older we're more likely. Family history, if somebody has a family history with some mutations. Hormonal factor like early menarche, that means early periods, and late menopause, that will all cause they're all the risk factors. Obesity is a risk factor, alcohol, HRT can be. So I don't know if you remember my talk on hormone replacement, where we said that the combined hormone replacement therapy, that's estrogen, progesterone, the progesterone aspect of that increases the risk of breast cancer. So we know that. Program we do to target the women is Ontario Breast Screening Program. Age, what are the recommendations? So it's definitely available to women over the age of 50 to 74. But recently, the ministry opened it for women in the age of 40 to 49. So they said, okay, it's an option for you. And it's risk-based. But honestly, I have been telling all my women over the age of 40 saying that if you want to have a mammogram, I'm very happy to do it for you, because any woman is high risk, and why not? Why not pick up early if you can, right? So I have been doing it. I know we talk about radiation exposure and all that, but I've been getting my mammograms since I've been like 40, because my maternal aunt had breast cancer. But if even if I didn't have risk factor, I'll still go for it because I see so many women. So it's good too. High risk women are the ones who have mutation like BRCA mutation. Then they have annual MRI and mammogram both. What happens with that is that there's a mortality reduction of 20 to 30% with screening. So 20 to 30%, if you can reduce that number of deaths that happen because of breast cancer, it's a huge thing, right? That you don't let someone go that far, that you don't allow them to reach that stage where we can't do anything. So we want to do something about it, right? Hence, there is effective breast cancer screening. Colorectal screening program. Colorectal is second to third most common cancer in women. First most common is breast. Colorectal is still very prominent. Incidence rising now with in younger group, less than 50. Previously it was more over 50, but we are seeing more young people now. I've seen more men than women, but to be honest, anyone can be at risk for colorectal. And we have again a really good screening program. So we say age above 50. These are the risk factors: diet, red meat, processed meat, sausages, bacons, all the fun things. Also excessive beef consumption, red meat consumption is a risk factor. Obesity is a risk factor. Sedentary lifestyle, family history is very, very important. So I always ask my patient when they join me as a new patient, I say, okay, do you have any family history of breast cancer or colon cancer? And that's a really useful question. So let's say your family history is clear, but now you suddenly find out that the family members who have breast cancer, then you let me know. And they have colon cancer, then you let me know, because your risk has changed now, right? And we'll try to work around that. Inflammatory bowel disease, if somebody has ulcerative colitis or Crohn's disease, celiac disease, things like those, they are high risk because their gut is already inflamed. And when the inflammation is already happening, then there's a small chance that those cells can turn into cancerous cells or precancerous cells. So we want to be on top of these things. Colon cancer program is called colon cancer screening program, and there are different ways of doing it. Those who are average risk, that means patient above the age of 50, they get the FIT test every 2 years. So you receive a kit at home every 2 years, but it's initiated by your family physician. So potentially we will request this for you, and you receive a kit at home, and then you do the test every 2 years. So it's like a cycle of 2 years doing the FIT test, which means you get a kit at home. It has a clear instruction what you do, and it's like a stool sample check, basically. And if it's positive, if it shows that there's hidden blood in the stool, then we send you for colonoscopy. High risk for colonoscopy, so colonoscopy starting earlier than 40 years of age, and you do it every 10 years. So let's say if somebody had a close family member with colon cancer at the age of 50, then we'll send them for colonoscopy at the age of 40, right? Just to be on top. And what they see in the colonoscopy, sometimes they'll see something like polyps and, things like those. They'll see polyps, they'll see some of those things which raise the alarm bell that there could be potential risk for the colon cancer. So it reduces the mortality, the colon cancer screening, by early detection and polyp removal, which is great. So see the incidence of the cancers are like here. So cervical cancer is still low. It's 7 to 8 per 100K. Lifetime risk is less than 1%. Breast cancer is very high. Lifetime risk is 12 to 13. It's a big number, right? Colorectal is moderate, 5 to 6% risk of colorectal cancer. And these are the screening programs. Overall risk for any cancer is smoking, obesity, physical activity. Then you have alcohol, genetic factors, and then hormonal factors, hormonal exposure. So if somebody had hormone replacement with progesterone, you have to just keep an eye. Then we go on to bone density screening. Bone density is more and more relevant as we get older. So, when we are above the age of 50, then the risk is higher. So after the age of 50, 1 in 3 women will have a weak bones, which is huge, right? 50 is just around the corner for me, so I'm scared. But anyways, a few years to go, just about 3 years to go. So anyhow, so major cause of fragility fractures. So, people get easy fractures. So a little bit of fall or a slip or a trip would cause fracture, like hip, spine, wrist. They're the common. Menopausal women are highest risk because the estrogen will fall, right? So I think estrogen is one thing that, as it goes down, women become more susceptible to certain things. And this is one of those things. Risk factor, age, being menopausal, previous history of fracture. So if somebody had a fracture in the past, they're more likely to get it again. Being very slim. So, I don't know if you've seen some women who are skinny. They have less muscle mass to protect them. And I think they can be quite high risk for the fractures. So anorexia, some women tend to be anorexic when they're young, and they get older again, they continue the same body structure, they can be high risk. Smoking, alcohol, use of steroid, certain drugs can do that too. Family history, and conditions like rheumatoid arthritis is another one to keep in mind. What do? We do a DEXA scan. We do a scan. We have a fancy scan available to scan your bone density, and that tells us if you're normal or if you are osteopenic, which is like weak bones, or brittle, which is osteoporosis. So bone density is something I would advocate to women. I actually do it early, I sometimes even initiate a little bit earlier. Certainly, if somebody has been menopausal for more than 10 years, I would not think about the age. I'll just do it. So this is another thing. Now, screening recommendations, Canada and Ontario. So women over 65 screen everybody, but you can screen early if they have steroid use, fracture in the past, or there's some high risk conditions which would make them more prone. And there's a special clinical tool that the doctor can use called FRAX tool to identify who is high risk, and that looks at a lot of things like age, family history, medication use, and all those things. So that's another way of looking at it. Screening interval, it's done every 5 to 10 years. For somebody who is low risk. Somebody who's moderate will do 2 to 5 years. Somebody who's high risk or they're on certain treatments like steroid, we'll do it kind of as needed. So sometime I'll do it even every 18 months or so. Why it matters? Why does it matter? So I don't know, you might have seen your parents, suddenly declining after a fall or a fracture. Or you might have seen that they have suddenly a fracture of the spine without a fall. We call it wedge fracture or, compression fractures, where, they didn't do anything. It's just the spine is collapsing, and sometimes even breaking. Compression fractures, they happen without any reason. It's just bones are too weak now. So hip fractures, vertebrae fracture, they can happen. And if we find out that you're getting weak bones at the age of 65 or 70, we can hopefully prevent that fracture in future, because you can get a fracture very easily. If you just have a smallest fall, and if your bone is weak, you break a bone like a wrist or hip. So we are going to be careful. Then we have aneurysm. So this is abdominal and aortic aneurysm screening. This is new, actually. It didn't exist before. It's been introduced kind of recently. So what that does, we have an artery, a big artery in our stomach, in our abdomen here, called aorta. Now, what happens is a massive, large artery with large thickness, and that is a huge artery which supplies the blood to majority of your body, the abdominal aorta. So normally we call it dilated if the dilatation of aorta is more than 3 centimeters. So you go for a scan, like you go for ultrasound, you go for a scan in a place, and they will check for this aorta and they'll scan it. And they say, okay, the thickness it's more than 3 centimeters, and that is serious, because if it keeps going wider and wider and wider, at one point could just rupture. And AAA, which is abdominal aortic aneurysm rupture, which is the biggest emergency, medical emergency I've seen in my career, because it doesn't give you time. It just big artery ruptures, and we can't do much about it. We can't fix it very quickly. It's huge artery. It's common in men than women. Low risk of rupture in women. Risk factors: age, smoking, family history, blood pressure, and atherosclerosis means that your arteries are calcified. So somebody who's got risk of heart disease, like a heart attack, they'll also get a risk for aneurysm, a triple A, we call it abdominal aortic aneurysm. How do you screen it? Easy check, very easy, just an ultrasound, very easy. So if you're over 65, you haven't had one, please let me know. Screening recommendation, it says general population, routine screening not recommended for general population. You do selective screening based on the reason, right? Over 65 or women for early PAP screening and all that, cervical cancer screening. Men, you would do 65 to 75, they've smoked. So routine screening not recommended for general population. We're talking still about the bone density, I think. Age more than 65, or you have a history, then you will do it. So this is the management based on the size. So this is how you manage it. If the aorta is less than 3, you don't do anything. 3 to 4.4, it's that thick, you monitor. If it's that thick, up to 5.4, you do very close monitoring. More than 5.5, it's going to break because the walls are now thin. It's getting wider and wider. You send them to surgeon. Why it matters? Because often people don't have any symptoms when they rupture, and rupture means 80% people die. Who do you scan? Women. So target population, women over 65 for bone density. And what do? You do DEXA scan. We're talking about the bone density here. Frequency, you repeat that. AAA, we'll do high risk for women over 65. Ultrasound, usually one time. So it says AAA is not like you do every so often. You do it just one time, right? If it's normal, then we don't need to keep repeating it. So this is all some of the screening. Now I'll do immunization, which I think is kind of important. Immunization means we talked about Gardasil, which is hepatitis HPV, human papillomavirus vaccine. Tdap is tetanus. Meningococcal vaccine is another one that we can offer. This is something we give to adolescents. Adolescents, when they're in the school age group, 13 to 15 years of age group, they get tetanus, they get HPV and meningococcal. Women in the reproductive age group, they get HPV catch-up if they've not done it. They get flu shot, COVID. We're forgetting these things now, but they still exist. Pregnancy, you get certain vaccines. These are the ones. Women over the age of 50 years, actually that's not true. Shingles vaccine is available from the age group of 65 to 70 only. I don't know why. It's only available over between 65 to 70, but you can get it on insurance. So we recommend to women after 50. Pneumonia vaccine, you get free over 65. RSV vaccine is a respiratory syncytial virus over 75. Flu annually, it's free. And I would say COVID vaccine. So many stories about COVID vaccines, right? We can write a book on it. That some people think it's the biggest problem they've ever had in terms of vaccine, made them this and that and everything. And I don't know how true that is, but I think we just need to keep an eye. I do get one, say, COVID vaccine because I'm exposed, but it's a choice you make, right? So honestly, whenever I go on a holiday, I get my vaccine, COVID vaccine, 2 weeks before. because I don't want to be sick on holiday. So those are the few things. So that's my more or less my talk on vaccination and immunization. Do you have any questions that you want to ask me? Tell me.
Hi, this is Sarah. I do have a question. Hi. Um, Regarding the vaccination, I did write it down. Okay, the vaccination for the HPV, you said that Gardasil
Yes.
9.
Yeah.
Honestly, when I transferred my history, the health history from my prior doctor, I don't recall if I have mentioned it to you. How do I know I have get vaccinated before? I don't recall now.
It's a very tricky one. So
Mm-hmm.
Gardasil is something. If you're born in Canada and if you've done schooling here, you might have got it in the school.
No,
Um,
I came to Canada when I was 20.
Right.
So
So Gardasil is something that not many people will get it because it's not a part of your regular immunization program. And I don't think GPs offer it proactively as much as we should be. So if you have a previous medical record, you can look through it and see if you had the Gardasil vaccine. I can't find out otherwise because, like, for chickenpox, you can do immunity test. For hepatitis, you can do immunity screening, but for Gardasil, we cannot. We cannot do the immunity check to see whether you had vaccine or not. So it will be through your records.
I see. Well, it's almost how many years I have been with you now. So let's say, I want to be vaccinated.
Yeah.
Would that be any issue? Like, it got double or not really? If I'm not sure, let's say I go to a new country, they would consider me as completely a new person and then do the vaccination again. Are there any harm on that actually? If I get double the vaccination?
If you get again, if you have received it, no, I don't think so. There's any harm. No.
Okay.
Yeah, if you
Okay.
can try your best to find out if you had it or not, looking at your previous medical record, it's helpful. Or ask your pharmacy, have I ever asked for this prescription? If that's not the case, then yeah, we can get vaccinated. Yeah.
Okay. Great. Thank you.
Yeah, I think I've got a question from Maha as well, or Margaret. Go on, Maha.
Sorry, hi.
Hi.
Wanted to know a little bit more. I know that we've changed, you said, from PAP test to HPV.
Yeah.
I know that because of my history of breast cancer, does it matter whether I get into effect? Because I was supposed to be the 2-year program, and then it became 3, and now it's 5, and I'm like, do I I feel like I don't know if I wanted to wait 5 years
Yeah. Yeah.
because of the history also of my family. We have like very high cancer risks in that area as well.
Yeah. Yeah.
Just wondering
So
how that works.
yeah, so they are actually, I know 5 years sounds a lot because if you go to Brazil or many countries, they do once a year, right?
Yeah.
Many countries do once a year screening, but because this is funded by the government, they said, okay, we'll give you the better screening. We'll give you a effective screening, which is HPV, compared to what we were doing before. They said, okay, we'll do a more expensive screening or more effective screening, but we'll give it more every 5 years.
Yeah.
So unfortunately, the having a cervical cancer in the family is not a risk factor. But you being positive for HPV is the biggest risk factor if somebody is positive, right?
Okay.
So if somebody is positive for HPV, especially those very high risk one, remember I said 318, 16, 45 thing. If you're very high risk for those strains of HPV, then you have to be on the radar for regular screening, colposcopy, and everything. If
Mm.
you're in the mid range where you're HPV high risk, but your cells are normal, we bring you back for early screening, like 2 year. If somebody is immunocompromised, so they are on certain drugs like immunotherapy, chemotherapy, and all that,
Mm.
if they're on that, so what happens? HPV, our body can have HPV, and our body might be able to fight the HPV too, and it
Mm.
might not let it do what it wants to do. So it might just suppress it because our immunity plays a massive role. However, if somebody is immunocompromised, then HPV can become more active, and then we say, okay, we'll screen you every 2 years. So yeah,
So that's through a test.
yeah, that's
Okay.
yeah.
Okay. Thank you so much.
My pleasure.
Appreciate that.
Margaret, you have a question?
Yes, I have a question. I wanted to ask you because you mentioned about the menopause and all these hormonal changes, and I wanted to ask how I have to take drugs for my hair loss, and those drugs it just mess up the hormones a lot. Like there's a lot about testosterone, and how the hormones are changing.
Yeah.
When you're taking, and you have to take that for quite a long time to have any effect on
Yeah.
even just stopping the hair loss. So I was wondering, how does this affect,
So
and
which hormones are you on, Maha?
I am on those. I'm durasteride. I took finasteride for quite
Yeah.
a bit, which didn't help at all. But durasteride, it does help. So I think I'm gonna stay on it.
Yeah.
But then it's been already 2 years,
I'm
right?
not aware that finasteride will make you high risk. Not
No?
that I'm
Okay.
aware. It's anti-androgen, those are.
Okay. Mhm.
Yeah, but as far as I know, the finasteride shouldn't cause any kind of increase your risk for any of these things. No,
Okay.
unlikely.
Because
Yeah.
I read that durasteride, it's more for the hair on the forehead,
Yeah.
and it apparently works
Mm.
quite better than finasteride. But it does, when I read about it, it does say that changes. Uh, there's some hormonal changes there.
Yeah.
But they are mainly for men, right? We women take it, especially on the older age. I guess the doctors are comfortable with that, but
So most of the time, what we give for hair loss is anti-androgen because androgen causes hair loss, too much testosterone. As women get
yeah,
older, our estrogen goes down. When
yeah,
estrogen is down, testosterone goes up, which causes
hmm
all kind of symptoms, including facial hair, loss of hair, increased hair, all kind of things. So I'm not aware they increase the risk of breast cancer or anything
okay.
like that.
Thank you.
But what
Just wanted to know.
yeah, no, I'll put
Yeah.
cross check for you as well. It's the HRT. So the progesterone element of HRT is well
hmm
known to increase the breast cancer risk. Yeah, so
hmm
we choose the progesterone very carefully.
I see. Thank you.
Nicola?
Sorry about that. I was trying to get off mute. Um, for the pap test, you're saying that persons who are immunocompromised can request like within 2 years instead of waiting the 5 years. That's what
Yeah.
you said. Okay, and it doesn't have to be like a specific um type of disease or illness. It can be just once you are on certain drugs or you're considered to be For me, I have MS, so
Okay.
I'm not sure if that would classify
Okay.
as one of those cases.
So what you can do, Nicola, talk to me one day on like a Zoom call 1-to-1.
Okay.
Just tell me what drugs are you on because some of the MS drugs can be significantly immunosuppressive, like immunomodulators and all those things.
Yes,
If you're
one of them is, yes, for
yeah,
sure.
if that's what it is, I think I might put you on a 2 yearly program. I'll also check the guideline carefully. But if somebody is immunocompromised consistently because they're on a therapy that reduces their immunity, I would put you on a 2 year program.
Okay.
Yes.
Second question, for the HPV, you're saying that you, as an adult, you can get that, or
HPV,
uh-huh.
unfortunately, is not covered on OVID for
Okay.
adults. Yeah. They think that youngsters are more high risk because they're
Mhm.
more sexually active, they can have multiple partners, and so on. So, therefore, the vaccine is actually given to kids in school when
Yes.
they are grade 7 or something like that, grade 8, they get
Yes,
the
they
vaccine.
start on today. My daughter has gotten, I think it's 3, and I think they started from middle school.
Correct,
So
exactly.
yes.
Same with my son. So, but for adult population, it's not available. So, if you have any insurance of any kind,
Mm-hmm.
most of the time insurance company would be really
Okay.
okay to allow you. So
Oh,
just feel free to talk to me again. I can do a prescription for
okay. I'll do that. Okay, thank you. Okay.
you. Yeah, any more questions? Do you guys want me to cover a specific topic next time? Is there anything that's a burning issue that you want me to cover? Or you can email me. Just email it to me, and then I'll work on that. I was thinking
Okay.
about maybe doing bone health in more detail and supplements for the bone health, like,
Yeah.
yeah, does that appeal
Great.
to you?
Great.
Yeah, that would be amazing.
Yeah,
Yeah.
let's
Yeah.
do
Yes,
that.
that would be great.
Because bone health, how we can improve our bone health, eventually, I just feel that body changes, we change, and how we can make sure that we maintain that, stability, right? And stay low risk to get fractures and so on. So I'll maybe talk about bone health and supplements next time.
Yeah. That will be good.
All right.
Dr. Rowett, I found your program is amazing. So I just want to ask you, is it okay to refer to my sister if she might be interested to join this?
You can refer. She's not my patient, right, Sarah?
She is not.
Yeah.
Yeah.
So what she needs to do, she needs to just do one consultation with me,
Mm-hmm.
because I need to just educate her how I work, because if she
Yeah,
just comes in on a Zoom without knowing who I am,
that's right.
it's a bit of a no, she has no rapport with me. So if you tell her to book an appointment with me one day in the office, I'll meet
Mhm.
her, explain her about my program, and we'll get her on the program. Yeah.
Okay, okay. So, but she definitely need to visit you in the office in order to join this coaching.
Just to get
Mhm.
a rapport and relationship with me. And
Okay.
she might find that, okay, this is not the right person for me. And suddenly I have to get this person on a Zoom call, right?
I
So just
see.
let her
I
have
of
a
course. I'm
one-to-one meeting.
gonna let her know. I find it's amazing. You don't get the interaction, learn all this from the other doctors. I definitely would recommend it to her, but I just want to know the process, how to get on. Yeah.
Yeah.
Okay, sure. Thank you.
Yeah, just drop an email, Sarah, and I'll let Maria
Hmm.
know as well about it.
Yeah, great.
Yeah, no, I'm happy to see you all. At least I'm able to deliver what I'm learning.
You
Yeah.
did amazing job. Thank you.
All right. Okay, then.
Thank you so much, Dr. Robot.
My
Yeah.
pleasure. Take care. Nice to
Thank
meet
you.
you.
Thank
Thank you
you.
Thank
very
you.
much.
Bye,
Bye.
everybody.
Bye.
Thank
Thank you.